There we go. Recording is in progress. So, Scott, why don't you go ahead and please introduce yourself and then take it away?
Great. Let me share my slides. Um, great. So you guys can see the slides, right?
Yes. Great.
Great. Well, happy to speak to you all. I appreciate the opportunity. I'll present for about 10 or 15 minutes, and certainly if there's any questions at any point, feel free to ask. My name is Scott Jones. I've been working with Priovant for many years and helped run this clinical trial that I'm going to tell you about. And so I've been working with many of the myositis physicians in the United States and around the world to get this trial enrolled, executed well, and design it, frankly, so that it was patient focused rather than a lot of trials which are not thinking about the person that has to participate in the trial. We wanted to make sure desperately that this trial was focused on the patient's experience and doing it so that they would get the most out of it. And then ultimately we would get results that mean something to patients, so that we could then both compel the FDA to approve it and patients to be excited about it. Because otherwise, why are we didn't get into rare disease as a company. So our company is called Priovant Therapeutics. Our whole focus is rare autoimmune conditions. And the very first study that we did was this study in dermatomyositis. Obviously, it is a rare condition. You don't work in rare conditions without caring about getting treatment to patients. So that's the whole reason we're doing this. And we're doing everything we can to move as quickly as we can to get this drug approved by the FDA and then available for patients' use. But that's not up to me. That's up to the FDA. So I will, let's see. I'm going to talk to you about Valor, which is the clinical trial that we ran. It is the first positive phase 3 trial for any modern targeted therapy in dermatomyositis, which is pretty exciting. If you look at conditions like rheumatoid arthritis, which you've probably heard of, or ulcerative colitis or Crohn's disease, there have been 20 or 30 new targeted therapies in those conditions over the last 20 years. And conditions like dermatomyositis has been ignored. There's been nothing targeted or novel for that condition. Obviously, there's IVIG, which was approved several years ago, but that is a drug, or that's a therapy that's been around for since the 1950s, is not specific to dermatomyositis. And here, what we're trying to do in the modern time is find um, therapies that are targeted to the specific pathways that are upregulated in dermatomyositis. So once daily oral pill that targets the key immune pathways driving DM, as I described. And patients were evaluated in this trial either on brepocitinib or on placebo. All patients were adults with dermatomyositis, and that trial took place for 1 year. It was a 1 year trial with then another year of an open label study where every patient had access to brepocitinib. And what we saw was that there were clinically meaningful benefits were seen in the overall myositis disease activity, skin and muscle symptoms, physical function, meaning was the patient able to do their activities of daily living, and corticosteroid reduction. So we know that steroids are a big component of treatment in DM. They have many risks, and we wanted to reduce that as much as possible through steroid tapering. So this is a potential breakthrough in the treatment of DM. We're going to submit to the FDA in early 2026. We're working as far as thousands and thousands of documents about a decade's worth of research that has gone into this drug that gets written up and compiled for the FDA. Obviously, the brepocitinib has not yet been approved by the FDA, and the FDA has not determined that brepocitinib is safe and effective. So I'm not here to tell you about anything other than what the trial said, but I can't speak to safety and efficacy. Okay. I don't need to tell you guys, DM is a rare and serious autoimmune condition that causes inflammation in the skin in some typical patterning and inflammation in the muscles that leads to weakness in sort of the muscles of your shoulders, thighs, core. Um, and they can also affect other organs like lungs or your heart. And so it is a serious condition overall for which there's not been great therapies developed to date. And there's been some really interesting research over the last years. This is from studies that have happened just in the last couple of years, where at Johns Hopkins, they polled patients and said, how are you experiencing your disease? And 73% of patients said I've had a flare in the last year, and 72% of those patients have gone to the hospital. And then quite surprisingly, this is from UT Southwestern, 97% of patients said they experience pain as a result of their myositis, which I think is one of the most poorly understood symptoms of DM and myositis in general. That doctors, when I tell this to doctors, they're like, really? Nearly all patients experience pain? And so it's always a surprise that is, doctors find that surprising. And that 57% are using opioids in order to treat their pain, which is obviously something that we want to prevent as much as possible and reduce that pain. So again, for decades, little progress has been made in the treatment of dermatomyositis. And the Valor trial marks a turning point because this is now the first positive phase 3 trial. So something where we can go to the FDA, submit the results, and hopefully get approvals that has ever been done. So what was studied? Adults, 18 to 75 was the age range, who had a diagnosis of dermatomyositis, participated for a 1 year randomized study. So they were randomly assorted into different groups, either groups that received brepocitinib, which is the investigational drug, or placebo. And the pills looked identical. They just looked like white pills that you had to take. You couldn't tell what you were on. Nobody knew. Doctors, patients, me, nobody knew what they were on except the computer. And so that is how this trial was run. And the question was, can brepocitinib help improve the key symptoms of DM, this muscle weakness, the painful or itchy rashes, and then the overall measures of well-being? There's sort of a global assessment of whether or not patients are happy. And so what did we find? We found that the patients treated with brepocitinib experienced meaningful improvements in muscle, skin symptoms, and daily functioning. Those, as I'll show you, those results happened as early as 4 weeks. So while some of the treatments that patients use nowadays can take much longer periods of time to show efficacy, this showed really dramatic improvement in 4 weeks. And then that improvement was sustained for the whole year-long period of this study, which is also not also a given, because you can expect that some therapies work well at the beginning and then stop working well after 6-9 months. This was not the case. It was sustained for the whole year. So you can see that here, and you're looking at 3 different groups. There's the dark blue bar, which is brepocitinib 30 milligrams, which was the highest dose. The light blue bar, which is brepocitinib 15 milligrams, so half the dose, and then placebo. And you have equal numbers of patients in those 3 groups. And the score here is called the mean TIS, or total improvement score, where you take a lot of different scores. It's a measure of muscle activity, patient-reported health, physician-reported health, non-muscle activity, and then also a scale that measures how well is the patient doing activities of daily living. Can they walk for 15 minutes? Can they pick up a bag off the ground? Can they get up out of a chair, get out of the bathtub unaided? Those sorts of things. So all that is compiled into a score. And you can see here that all groups get better. There is the placebo effect. Even patients on placebo think they get better. So what you're always looking for is the difference between placebo and drug. That's why you do placebo-controlled studies, because even patients who are on placebo think they're getting better, which is fine. That's why there's a placebo effect and why we do studies like this. That's why you see all these numbers go up. But you can see with the little asterisks that exist over each one, that's saying that there's a significant difference between the lines. And so you can see this dark blue bar is much higher than the gray bar. And then that very quickly separates, and you see clear separation between patients on placebo and the patients on brepocitinib 30. And so there's a clinically meaningful separation and statistically significant, which the FDA cares about, is the statistics, all the math of it. And so we can see that the higher as the scores go up, patients are improving. Okay. What we saw was that also meaningfully, brepocitinib helped more people lower their or completely stop their steroids. So patients could come into the study on oral corticosteroids, up to 20 milligrams of prednisone a day, and 62% of those on brepocitinib were able to lower their steroid dose to 2.5 milligrams a day, so significantly lower, and 42% completely were stopped. And then the point is maintained their improvement. So it's not as if they stopped their steroids and got worse. They stopped their steroids and kept maintain their improvement, meaning that ideally what this means is that the drug is able to support a patient getting better while they reduce their steroids simultaneously. And that to me is the whole mission here of what we're trying to achieve is better health with fewer drugs. Whether or not that's the case in the future, we'll see, but that is what happened in this trial. Okay. Then if we look at skin disease, there's another measurement, a form that doctors fill out that shows how much skin disease patients have. And so in this case, numbers going down indicates improvement. And so again, you can see the dark blue bars, brepocitinib, the higher dose, then the middle dose, and then placebo. It's always good to see this like stepwise fashion. It's called a dose response, meaning that a full dose has full efficacy, a half dose has less efficacy or less impact, but some, and then placebo. So that's what you always like to see that. But you can see really strong improvement at 4 weeks, patients getting their skin disease really clearing up, and then that extending over time. This is an example of a patient, so you can see they've got sort of the typical pattern of DM of upper back and the V sign, and then over 12 weeks, that's already started to improve, and then by week 52, it's completely gone. Even potentially some of the like dyspigmentation reduced from week 12 to week 52 is impressive. Similar here, this is a patient with ulcerations on their thigh. And then you can see at week 12, that's largely gone. Lots of the redness is gone. And then by week 52, everything looks normal. So patients who had really severe skin disease, they saw more than half of their skin disease go away by week 52, and nearly half of them achieved what is called clinical remission. So they achieved a very low score on their skin disease, which is good. And so nearly half of them in 1 year were able to reduce their activity to almost nothing. And that's again really powerful given that skin disease can often be the thing that prevents patients from getting better. And here's another example of that with a patient with ulcerations on their elbow and forearm and lots of redness and scaliness on their forehead. Then again, at week 52, all of that is gone. Patients or photographs often say more than all of my dumb graphs. So that's why I like showing the photographs. Muscle strength. So this is a measurement of muscle strength, similar picture. Patients get better over time if they're on brepocitinib 30 and patients on placebo don't. You actually see this, I think, is a good example of the placebo response. They get better up to week 12 and then stop getting better because at a certain point, they're like, I'm not actually feeling any better. I just thought I was. And so then that plateaus out. So you see, again, strong improvement in patients' muscle strength as well. And we know that dermatomyositis significantly impacts their quality of life, climbing a flight of stairs, walking for a mile, bending to pick things up. So the typical activities of daily living are strongly impacted. But when we look at sort of how the patients did on the trial, again, a decrease here is improvement. This is a health assessment questionnaire. And so patients in the dark blue are on brepocitinib 30, and you can see that they improve really well by week 52, whereas patients on placebo, the gray bar, get better initially, like I described, and then realize they're not actually getting better. And by the end of the trial, they've shown no improvement. And this is in the things that patients really care about. Can you bend over, pick things up? Can you get out of a chair? All those things on this previous slide, that's what makes up this score. And here we see only improvements for patients on brepocitinib 30, and this gray bar indicates where is the meaningful change. It's only in this gray area. So you can see they achieve a meaningful change by week 12, about 3 months in. Okay. So how does the medicine work? It's a once daily oral pill that blocks part of the immune system that are overactive in DM. What we saw was generally well tolerated with a safety profile that's consistent with prior brepocitinib clinical studies, which were done in other indications, and FDA-approved TYK2 and JAK inhibitors. So there are other TYK2 and JAK inhibitors that are currently available, and this has a similar or a safety profile that is consistent with those drugs. There was a numeric increase in serious infections with brepocitinib 30, consistent with other inhibitors of TYK2 and JAK1, so that was not a surprise. And adverse events of special interest, which is sort of a cumbersome phrase, but that includes malignancy, cardiovascular events, and thromboembolisms did not occur at greater frequency with brepocitinib as compared to placebo. Sometimes that can be a concern with this kind of drug, and we did not see any increased number of those events in this trial. But again, this has not been approved by the FDA, nor considered safe and effective by the FDA as of yet. Okay. So we're really excited about this. Obviously, we're really excited about to get this to patients. That's what I spend all of my time doing, is trying to get this ready to go to patients. Um, and so it's the first successful registrational trial for a targeted therapy in DM. It's the first successful 52-week study. Most studies are much shorter, but it's important to look at how it works long term. It's the first placebo-controlled trial of any kind for a once daily oral therapy, and it is the largest trial. It's 240 patients, 241. And the other largest study was only 90 some odd patients that was successful. So this is a huge amount of information about dermatomyositis, which we're excited to share as we learn more, as we study to get more information from the study. Okay. That's all I had. So as I said, we're moving quickly towards a submission to the FDA. Our expectation, we're hopeful that we're going to have approvals from the FDA towards the end of next year. I don't work for the FDA, so I can't tell you precisely when that'll happen, but I can do everything I can to make that happen. And hopefully that brings a new path forward for patients. Okay. Thank you very much. I appreciate everybody's time and attention. I know it's late in the evening, and all these graphs and everything cannot be that interesting, but this is really exciting is the point. It's like we couldn't be more excited about this. If anybody has any questions, I'm happy to answer if there's any specific questions about the study.
Thank you, Scott. Oh, fascinating, and so nice to see positive results from a clinical trial, especially the gold standard clinical trial, the placebo-controlled. So that's really, really nice. Questions for Scott?
I guess I have one. So interstitial lung disease is a one of there's several drugs that aren't so recommended if you have interstitial lung disease with your dermatomyositis. Were there folks participating in the study? I was really impressed by the study size, in particular, doing a lot of reading about studies and drug trials, looking at the pool of data, how many folks are being tested. Were there folks in this testing lot that did have interstitial lung disease or other kind of complications that come with dermatomyositis?
Yeah, what a great question. You should come on the road with me and ask that question everywhere. That's the right question. So about 20% of patients had interstitial lung disease who were in this study. Now, I will say this was not a study measuring the impact on interstitial lung disease. So I won't ever be able to tell you, does it work I mean, I can't tell if it works at all. That's not my job. But I can't tell you specifically what happens in interstitial lung disease. What I can tell you is that one of the scales that we are measuring in this is called the extramuscular global activity, means all the activity that isn't muscle. And that includes a lung domain. And so and physicians fill that out. And so they can see how do the patient's lungs doing in the course of the study. And we have that information and we're looking at that now. But there is no sign that those patients who had ILD got worse during the study. In fact, it's quite the opposite. They look like all those graphs, like they do just as well as anybody else. Further research needs to be done to really know if this drug works for interstitial lung disease, and that's something we want to do as soon as we get approvals.
Yeah, especially like methotrexate is one of those ones. There's some drugs that just cause other unknown side effects that can
Right,
cause even
right,
additional scarring or things like
right.
that.
That's right. And I'll also tell you that as we look at the backgrounds of all these patients, we wanted this to be a real population of DM patients, not sort of a make-believe, the healthiest version of DM patients, which is why we were happy that 20% had happy. We were glad for the study that 20% had ILD, but also nearly half of the patients had some sort of cardiovascular risk, because that is a common feature and a common risk to these patients, to patients with DM, is cardiovascular health. And we didn't want to exclude all of those patients. So we included patients with hypertension, hyperlipidemia, obesity, and a variety of other histories, or tobacco use, etc. So that led them to being riskier patients as far as like having cardiovascular disease. But we wanted that to show that, again, in this study, there was not an increased rate of cardiovascular events as compared to placebo. So we're looking at a very real world population of patients. That's a great question.
Thank you. I appreciate it.
I have a question.
Please.
I understand that the trial was randomized, but did you see any trends in patients that responded best? Like differences, whether the patients had like dermatomyositis, like long-standing dermatomyositis, maybe a new patient, or the dermatomyositis was more centered on the skin or the muscles, like any trends within those differences?
Yeah, what a great. Um, no is the punchline to that answer. What we generally saw is as you look at, we haven't done a ton of this yet, so a lot of this remains to be done. But generally speaking, as we look at different groups of patients, like severe skin disease, severe muscle disease, ILD, over a certain age, under a certain age, they do well, or they do as well as the general population. Like the study, when you look at those curves of the total improvement score, that's how it sort of looks for a lot of the groups that we look at. There's a lot more groups to look at, to be clear. Like there's a lot of ways you can cut this data and look at that. What the data says is that over 2/3 of patients saw a moderate response, or what is called a TIS40, total improvement score of at least 40. And that means that they saw at least a moderate improvement in their overall disease. So more than 2/3, it's hard to cut that up and be like, well, what's the 1/3 that didn't see that? Are they all, a certain
Mhm.
subtype? No, is what we're seeing at the moment, but we're
Okay.
going to continue looking at that.
Okay. Thank you.
Yeah.
Well, where do you imagine and maybe this isn't the right question until the FDA approvals here, but where do you imagine the drug coming in terms of the treatment cadence for dermatomyositis? I mean, is this going to be a first line drug, a second line drug? Before you get to infusions, after you've failed infusions? I mean, what do you kind of imagine the positioning for this?
Yeah, really good. So not for me to say necessarily, but I have talked to many physicians about precisely that question. And there's a couple of ways to think about it. One is it does depend on what the FDA says. And so there will be potentially some rules about what has to come first. However, I think what we've shown here, as I described, is that this drug allows patients to come off of, a lot of the patients to come off of their steroids or to really significantly reduce them. One of the big risks, as we've been talking about malignancy and cardiovascular health and thromboembolisms, one of the big risks to all those serious events is steroid use. So if you can get your steroids down as quickly as possible, it reduces that overall health risk. So there have been many physicians like Ruth Ann Vlegels at Harvard, Lisa Christopher Stein at Johns Hopkins have said, I want to use this drug earlier because while we may do a steroid burst at the very beginning, if you also use this drug early on, then I can get your steroids off pretty quick, potentially, right? We don't know yet, but that is a potential path. So using these targeted drugs early may be better. That's where I see it figuring in. This would only be the second thing ever approved for dermatomyositis. So there's not a lot of, in theory, on-label options. And IVIG, which is approved and is a drug or a therapy that people can get access to, is tough to get access to is the problem. And having a once daily oral therapy, I leave that completely up to the patients and the physician to say, okay, here are our options. What path do we want to go down? There are risks and benefits to every drug and every therapy, and that is a conversation for a person and their doctor to have together. But I think as we learn more about this trial and what the FDA has to say about this drug and submission, I think there's a potential for this to really play an important role in the treatment of DM in early days.
Terrific. Courtney, any questions?
I actually do have one question. You had said that there was a 15 gram, I think you said, and then a 30. How does it work? Does the patient automatically start at 15 and then titrate up, or do they just automatically go to 1. If it doesn't work, they go higher. How does that work with the scheduling of it?
Do you mean in the trial or in real life?
Well, I guess in both, because it said 15 and 30, so I wasn't sure if that's how it was going to be later on for the patients, like
Yeah.
if they have to do one, then go to the next, or if you can go on a low dose and stay on a low dose, if that's working for you.
Yeah, good. So the reason we did two different doses in the trial is because we did not do a phase 2 trial. So typically
Oh,
you do phase 1 studies, phase 2 study, phase 3, right? And we didn't do phase 2. We were just like, this looks too good to be true. Like it's great. We want to do Dermato. Let's not waste everybody's time. We want to move quick, as I've described. Our goal is to get this to patients. So we've done a phase 2, but it added a whole another 2 years to the process. So the FDA was like, use two different doses to see what's going to work. And so we used 15 milligrams and 30 milligrams. 30 is the only one that worked. So,
okay.
and worked, like achieved a statistically significant and clinically meaningful difference between placebo. And so that's what that means. And it's achieving the primary endpoint of the trial. Only 30 milligrams did that, 15 milligrams didn't. So we're only going to the FDA with the 30 milligram dose. And so in clinical practice, you would be given 30 milligrams. There won't be other doses approved. In theory, that I don't know what will happen, but that's my expectation based on the results.
Thank you for explaining.
We're right at the end of our time. I'm going to ask one quick question because with the 1 minute left, and that is, you guys doing anything for IBM?
What a great, yeah, man, you guys are harder than the physician meetings. Um, I've had many discussions about IBM over the last few weeks with people who say, let's try this drug in IBM and see what happens. IBM's a really hard, a really hard disease. It's really hard for patients. I mean, it's really hard. And so we're really motivated to try and figure out something how you need the key components. You have to design the trial so that it like gets you an answer that is useful. Yes or no, but you need to be useful. And so designing the trial is what's important. And that's what I'm trying to work with some of the world's leading experts in IBM right now to talk about, okay, what would a trial design look like that could be useful in this kind of condition? So no, but maybe one day soon is my answer to that.
So for those of us with IBM, we encourage you to keep plugging away at it.
I appreciate that.
Okay.
I'll be honest, that is helpful because
No, really, because I mean, well, there's two, as you know, there's two active clinical trials right now,
yes,
but hopefully one of them will show us something.
yeah,
But right now there's nothing. So it's
yeah,
so yeah, so encourage you
yeah,
to keep looking at it, and really appreciate the fact that you guys have been doing this level of good work with dermatomyositis. Sounds really promising, and I'm sure all of everyone with dermatomyositis is looking forward to that FDA approval and to figure out where this might fit in their own treatment plans.
excellent. Well, I appreciate you inviting me to speak today. It's really generous of you.
Thank you so
Thank you
much.
so much for coming. Really appreciate it.
Thank you.
Cool.
All
Thank you.
right. Good night, everybody.
Thank you.